choice of oral antidiabetics in CKD. And as the speaker, we have none other than the backbone of HDS, Dr. Sanjay Shah. Sir doesn't need any introduction, but I would like to introduce him very humbly. He is the senior most endocrinologist of HARA, HOD of Endocrinology Department of Narayana, and he is the founder president of HDS. I welcome you, sir, on the dais. And with him, we have the chairpersons as Dr. M.L. Bhansali, who is the vice president of HDS, and he is known for his huge practice in medicine, academic, and research. With him, we have Dr. Narayan Bhattacharya, who is a practicing cardio-diabetic physician. Previously, he was in army, now back to his roots and practicing for many years. So I welcome speaker, sir, and the chairpersons on stage.
Good evening. I'm really thrilled, elated, and honored. এখানে অ্যাকচুয়ালি আমার দুজন স্যারের সাথে আমার প্রতিবার দেখা হয়, ডক্টর সমর ব্যানার্জি এবং ডক্টর শিবানন্দ দত্ত। আমি দেখতে পাই স্যারেদেরকে এখানে, প্লাস এটা আমার বাড়ির মতো। অ্যাকচুয়ালি ইউসিডি প্রোগ্রাম চলছিল, সেখান থেকে আমি এখানে চলে এসেছি। আর মৃদুল বা গুরু এরা আমার ভীষণ বন্ধু। তো আমার রিয়েলি খুব ভালো লাগছে, খুব আনন্দ যে আজকে এমন দিনে আপনাদের সাথে আছি। ডক্টর সঞ্জয় কে শাহ সম্পর্কে বলতে গেলে আমার ওই গানটা মনে পড়ে যায় যে তুমি কেমন করে গান করো হে গুণী, আমি শুনি শুধু শুনি অবাক হয়ে শুনি। নার্কোটিক অ্যানালজেসিক এইমাত্র স্যার বলছিলেন, আমার মনে হয় কলকাতাতে একজন নার্কোটিক স্পিকার আছেন যার টক শুনলে আমাকে অ্যাটলিস্ট আমার জন্য মানে বললেই আমি কোথাও চলে যাই যে ডক্টর সঞ্জয় কে স্যার একটা টক আছে। সেই জন্য এটা আমার পক্ষে ধৃষ্টতা হবে যে স্যারকে ফর্মালি কিছু ইন্ট্রোডিউস করানো। স্যার ইজ অলরেডি ইন্ট্রোডিউসড, আমি শুধু মানে এইটুকু বলছি। টাইম অনেক লেট হচ্ছে, সুতরাং স্যার প্লিজ স্টার্ট স্যার। থ্যাংক ইউ স্যার।
Thank you very much, Chairpersons Narayan as well as Dr. Bhansali. That's my photograph of younger days, perhaps 5 years old. Okay, so it's not that bad. It's a reasonably good representative of me. And that's perhaps what I have been doing for the past few years since I've come back to basically work here in India, and particularly at West Bank and then Narayana Hospitals, Howrah, per se. I must thank the organizers for asking me to speak. Why? Because the original speaker, Shottam, unfortunately for whatever reason, personal perhaps or something else that happened, I hope all is well, could not make it. So I must also thank Shottam for giving me this opportunity to be here in front of you. That's what I'm going to talk about, okay? And remember, my prize question will not be at the end of the talk, it will be while I continue to talk. And remember again, if you have ever taken an exam, the examiner is always right. Okay, so that is the motto of the whole talk, right? Choice of OADs in patients with CKD. It's the best way to essentially perhaps learn and share is by looking at a case, and that's what we're going to do. Then we look at the risks and prevalence of type 2 diabetes of patients with CKD. There are multiple factors and treatments in type 2 diabetes patients with CKD. We also know there are limitations of all these treatments that we have in patients with CKD. And then we'll have a brief look at the new drugs in diabetes and the effect on CKD, and then I'll conclude. I must, at first, before I basically embark on the case, thank Lupin for basically sponsoring this session. So you will, during this communique from me, have a couple of slides which looks as if the company has sponsored it. It is not like that, but perhaps you will see that along the way. At least some of my colleagues who perhaps do diabetes 95% of the time, just as I do, who are sitting in front as well. So let's get along with the case. RC, he's a 57-year-old man with type 2 diabetes, first diagnosed 6 years ago. He's currently on glimepiride 2 milligrams daily, metformin 2 grams daily, and vildagliptin 100 milligrams daily for his blood sugars. His other medical problems essentially is obesity as well as hypertension, but it's reasonably well controlled on medication. He's asymptomatic. Like a large number of patients in diabetes, he has no symptoms. His laboratory evaluation shows a trace of protein on urinalysis. His blood urea nitrogen is 12, which is normal. His creatinine is 1. his EGFR is 90. His fasting sugar is 106, PP of 160, and A1C of 6.9%. He has normal electrolytes. So my simple question, which is not a prize-winning one, is, does this patient have CKD? What do you think? Let's remind ourselves what we mentioned, okay? His creatinine is 1, his calculated EGFR is 90. So does this patient have CKD? Sorry, শুনতে পাচ্ছি না রে। সোমনাথ তোকে একটু জোরে বলতে হবে বা মাইক নিয়ে বলতে হবে।
From this,
The examiner is always right. এটাই তো বলছিলাম।
from this lab feature, it's not obvious, but the person may have CKD.
So what do you want?
Difficult. ACR, abdominal
Fantastic.
ultrasonography.
Bring a round of applause, okay, for Somnath. You can give him the prize gift as well to him. So does he have CKD? What we want is a urinary albumin level. You're right, Somnath, okay. 24-hour urinary albumin in this guy is 150 milligrams. Normal is less than 30. So he's CKD stage G1, A2. Why is it important? Here you are. This is basically the KDIGO CKD heat map. While we are used to basically talk about CKD in terms of EGFR, there is another aspect to it, particularly with diabetic kidney disease, albuminuria. So that is why you have A1, A2, and A3. For normal albumin, once you get microalbumin, and that means A2, and then you have macroalbumin. What is more important to basically understand, if you look at this heat map, is that the moment you have microalbumin, even though your EGFR is more than 90, that's the yellow panel, okay, in the middle one, it behaves as somebody who already has an EGFR of between 45 and 59, which is also in the yellow color. Okay, so microalbuminuria is serious disease. He's asymptomatic, remember, he has no symptoms, but it is serious disease. This is what happens to people with diabetic kidney disease. Kidney disease is powerful. It predicts increased mortality in people with diabetes. So if you can see that with no kidney disease, if your mortality rate is 4.1% per year, it becomes triple by the time you get albuminuria. And it then becomes even further higher, 4 or 5 times, the moment you start having impaired glomerular filtration rate. And if you have a combination of albuminuria and impaired glomerular filtration rate, it goes up to roughly 10 times. Okay, so albuminuria actually, though largely asymptomatic, is serious disease. What actually transpires, from what we understand, essentially DKD implies widespread vascular disease. And here it is, as your ACR continues to rise, the basically all-cause mortality rate continues to rise as well. So the prevalence of CKD in people with type 2 diabetes, approximately 40% of people with diabetes will develop CKD, with a small but significant proportion developing perhaps end-stage renal disease. Large number of them actually will die from vascular events. Okay, perhaps the data from KDIGO is roughly about 5% only will actually end up having end-stage renal disease. In India, there was a cross-sectional study done, which basically looked at multiple centers in their clinics, diabetes clinics, found that 46% of type 2 diabetes patients had CKD. If you took albuminuria included, while if you just took EGFR, perhaps only 23%. So a far large number of patients actually seem to have albuminuria, and maybe because they are largely asymptomatic, or we are not checking their albumin, we actually may be neglecting them, technically speaking. The risk factors for DKD, I always learned, and I'm teaching my son as well, there is always something called non-modifiable. You can't change it. If you don't remember it, it's okay. But you're going to age, you're going to have a longer duration of diabetes as you age. You can't change your parents, okay, and you can't change your ethnicity. But what is more important is you should know what you can modify and do. And we all know good sugar control is good for your kidneys. Must treat your hypertension, then the hyperlipidemia, obesity, smoking. Now this is a slide from the Caucasian database, okay? So they have recurrent infections fairly low on the list. In our country, I think recurrent infections perhaps is reasonably important, okay? Because our patients tend to get urinary tract infections slightly more frequently, I think. I don't think I have data to tell you that, but I think infections are fairly common in our country per se. We all know there's a wonderful study, the STENO-2 study, which showed that multifactorial involvement, be it you treat the glucose, you treat the blood pressure, you treat the statin, you stop the smoking, you actually will have remission. If you can manage to have remission to normoalbuminuria, it is associated with a decrease in GFR decline, okay, during a period of 7.8 years. So a multifactorial basically approach is extremely important. And that's the reason why an asymptomatic patient with microalbuminuria is significant. You can target multiple basically areas to try and make things better for him, particularly with regards to his vascular outcomes per se. I think we are very well aware, amongst the many diabetes-related complications, hyperglycemia is a very important, basically, pathophysiological component of microvascular disease. And diabetes is largely a microvascular, particularly DKD. So hyperglycemia actually drives DKD, okay, to a fairly large extent. And what is the proof? The proof is any drug which lowers blood sugar actually has shown that it basically protects or actually reduces microalbuminuria. So any drug basically in diabetes perhaps is reasonably beneficial as long as it lowers blood sugars. It basically tells us the importance of blood sugar control in diabetic nephropathy per se. Obviously, hypertension treatment is important. Also important is essentially avoiding infections, which perhaps is not easy to do in our setting. So the management of type 2 diabetes with CKD has several challenges. The high prevalence of comorbidities, as you've already heard, that they actually have vascular disease risk is very high. And there's a risk of increased hypoglycemia due to decreased clearance of drugs per se, as well as because of perhaps reduced appetite as well, and perhaps there's a change in, say, gut motility as well in quite a few patients. And there's reduced drug elimination rate. The commonly used oral anti-diabetic agents are either contraindicated or should be used at reduced doses in individuals with renal impairment and CKD. The treatment options, which are well tolerated and exhibit low risk of hypoglycemia, is needed. And I think Mridul showed you very nicely when he was talking about REMO as the SGLT2 inhibitors, that perhaps that also features as part of the treatment when you want to avoid basically hypoglycemia per se. But I think the take-home message is all drugs which lower blood sugar work, but you have to choose the drugs which benefit the kidney. So do we really have drugs which benefit the kidney? Before that, hypoglycemia is a risk for patients with type 2 diabetes and CKD when taking oral glucose control therapies. Why? Because CKD is progressive, okay? So it increases the risk. Hypoglycemia unawareness also increases, okay? Symptoms of hypoglycemia may be reduced in patients with CKD. So you must talk about hypoglycemia in patients with CKD in your diabetic clinic. Assess the risk and treatment of hypoglycemia, and then patients need to be monitored more frequently. Basically ask your patient to check more often rather than go by how they feel, okay? That is the problem. Because it's a largely asymptomatic disease, patients refrain from basically frequent testing. I can feel my blood sugars, if it goes up, if it goes down. Well, it's not that easy, but patient but you have to try and tell them, do the test. Okay, do the test. That is important. Perform frequent therapy reviews. So every diabetic kidney disease patient should see the diabetologist more often than the run-of-the-mill diabetes patients in clinic per se. You've seen this slide earlier, and you have also heard about it, that the compelling need to minimize hypoglycemia would essentially be, basically you can use either a DPP-4, you get a GLP-1 receptor agonist, SGLT2 inhibitors, TZDs. Do not forget that this is on top of metformin. So you can give metformin, and then you can use any of these drugs so that the risk of hypoglycemia is extremely minimal per se. And if you want to treat patients with CKD so that it benefits the kidney, not only does it treat diabetes, but it benefits the kidney, then you perhaps should choose to use an SGLT2 inhibitor, as seen on your right-hand side of the panel per se. SGLT2 inhibitors with the evidence of reducing heart failure as well as CKD progression in the cardiovascular outcome trials has been shown. So SGLT2 inhibitors are good drugs in terms of not only being reasonably safe, but actually benefits the kidney per se. So here you have a whole list of drugs that we use in diabetes per se: metformin, DPP4, SGLT2. Alpha-glucosidase inhibitors is used quite often in our country, and then the GLP-1 analog, which is essentially an injectable. And they all have their own mild side effects, actually. But what I'll try and focus upon, because of shortage of time, on the two new oral agents, which perhaps we have been using over the last 5 to 10 years in clinical practice per se. So, the anti-diabetic therapy in patients with chronic kidney disease, basically a summary: you can use metformin till a creatinine clearance of 60 for sure. Obviously, new data suggests that even up to a creatinine clearance of 30, it should be reasonably okay. You're okay with it. Okay, the risk of developing lactic acidosis is perhaps fairly small per se. What about other drugs? This is about the other drugs, sulfonylureas, particularly long-acting ones, perhaps would generally tend to refrain, and you have to use lower doses, okay, when you actually give it in patients with CKD. It's preferable to use glinides, ripaglinide in particular, because they almost behave like sulfonylureas, which are short-acting per se. What about acarbose and miglitol? And the picture tells you very nicely, the moment your creatinine clearance is reasonably bad, obviously you can't use them because of the side effects per se. Glitazones can be used throughout a patient's history of diabetes, but because of the fluid accumulation and heart failure and the edema and the risk of basically bone fractures, perhaps it's something which we don't use in clinical practice as much. But you can perhaps, if you want to use glitazones, maybe you'll be able to use it to control their blood sugars per se. Gliptins are reasonably good. They almost have placebo-like side effects, so you could use gliptins. Some of the gliptins you need to reduce the dose per se. What about GLP-1 analogs? Again, with a creatinine clearance of more than 30, you may be able to use it, but they are reasonably expensive, and essentially they are injectables. We are going to have a new one, which you'll be able to use it orally per se. And insulin, you can use insulin throughout the history of diabetes, whatever the comorbidities, per se, but the risk of hypoglycemia actually will be quite high per se. But that chart avoided a whole new group of drugs that we are interested in these days. The SGLT2 inhibitors, canagliflozin, empagliflozin, and dapagliflozin. And these flozins essentially have shown fairly promising data with regards to renal protection. So you can use it when your eGFR is more than 45 perhaps, but if anything less than 45, the drugs will struggle to really work. Okay, so that's the problem. It has a narrow therapeutic window. By the time your patient's creatinine is 2.5, perhaps these drugs in treatment of diabetes wouldn't have a place, because their creatinine clearance, technically speaking, would be perhaps less than 30%. So let's briefly look at the new orals, SGLT2 inhibitors and DPP4 inhibitors. The SGLT2, to my august audience, are aware that the sodium glucose link transporter is blocked, as Mridul told you very nicely, and as a consequence you have basically glucosuria, and that through the TGF, or what is called the tubular glomerular feedback, has effects on the kidney, which essentially is the afferent arteriolar constriction, and that's how it protects the kidney. And there's data to suggest that it does so, because if you look at the change in eGFR over 192 weeks with the use of empagliflozin, while the sudden deterioration happens in the first few weeks, maybe up to even 2 months or 3 months, and it then recovers, but over a period of time, this is a 192-week study, you can see very nicely how empagliflozin beats placebo when it comes to basically protecting the kidney per se, with regards to reduction in eGFR. And we have now got the results of CREDENCE trial, which use canagliflozin. Okay, canagliflozin actually showed some remarkable results. The end-stage kidney disease, the doubling of serum creatinine, the problems with renal or cardiovascular death, all reduced. Look at that p-value, p of 0.00001. Okay, so that is a fairly powerful, with a hazard ratio of 0.7. So about a 30% reduction in this very hard outcome, basically data with regards to the use of canagliflozin per se. So the SGLT2 inhibitors, orally active drugs, you have 3 of them. They improve renal outcomes per se, but they have certain adverse events. Genitourinary infections is one because of the glycosuria, and perhaps very rarely diabetic ketoacidosis. But above all, there's another problem. It has a narrow window. The moment your creatinine clearance is basically below 30, perhaps these drugs perhaps will not work. We'll have to see or watch for more data per se, but perhaps it's not going to work per se. What about gliptins then? Gliptins in type 2 diabetes with renal impairment, reasonably modest efficacy. It can lower A1Cs anywhere between 0.5 and 0.6%, as you can see in the data. No difference in the incidence of adverse events compared to the control group. Exhibits low propensity to cause hypoglycemia. And it's well tolerated and weight neutral. But it has placebo-like side effects. And the beauty of a gliptin essentially is that you can give it throughout a patient's diabetes history, whatever his basically kidney disease per se. Even the creatinine of 3. You have to choose the gliptin you want to use, and you have to choose the dose you want to use, but perhaps you can use a gliptin per se, even patients perhaps with hemodialysis as well. Now, thanks to again Lupin, who has perhaps market linagliptin. So this is nothing but a slide to tell you that linagliptin lowers microalbuminuria by roughly 33%. Okay. Now, is it true also for other gliptins? Other gliptins also have beneficial effects in terms of reducing microalbuminuria as well. But you had this Marlina trial, which essentially showed you that it had basically lowering of albumin. It is in addition to lowering blood sugars. So certain DPP-4 inhibitors in the nephrons as well are present, and perhaps the effect is through that, through basically reducing fibrosis, inhibition of podocyte damage, and so many other factors basically at the microscopic levels, which essentially basically protect the kidney per se. You have the Carmelina study, okay, which has been again last year been basically presented, which basically was a cardiovascular outcome trial, okay, but it also looked at kidney safety. And this study, when you gave a group of patients linagliptin compared to basically placebo, when you did it add on, what in terms of kidney disease it showed was that it was neutral to placebo in terms of hard outcome, okay, in terms of hard outcome. So gliptins, particularly if you look at it in that fashion, this is what it does. It has perhaps modest glycemic control. It has low risk of hypoglycemia, which can be a problem with kidney disease. It's weight neutral. It perhaps reduces significant reduction in albuminuria. Well, with regards to renal protection, well, it may not be that good in terms of renal protection, but at least it's as good as basically placebo. So you do not have a major problem with the use of gliptins throughout the life of a patient with diabetes and kidney disease per se. So that brings me to the last slide of my talk today. Diabetes and CKD is more common than we think. Okay, we have to look for them in clinic. DKD is a deadly combination. You've looked at the chart, how your vascular risk actually exponentially rises when you actually have nephropathy per se. Multifactorial treatment is the call of the day. We looked at the STENO2 study, and we showed you very nicely as to how you have to actually attack blood pressure, lipids, stop smoking, sugar, and everything else. All anti-hyperglycemic drugs have beneficial effects. We've seen that when we looked at the UK-PDS study. We've seen that when we looked at the DCCT study. We've seen that all the other drugs or studies that we VADT, basically telling you that when you lower blood sugar, okay, it basically will reduce nephropathy. Your microalbuminuria will come down per se. SGLT2 inhibitors are very good, but they have a narrow window. Okay, why narrow window? Because it becomes perhaps less effective or not effective when your creatinine clearance is less than 30. Okay, so narrow, and they have limited side effects. Maybe there is definitely some increase in infections. So you have to choose your patients correctly. And yes, the beauty of the drug is that it actually can protect the kidney. So you basically need to cautiously use it in your patients. You need to perhaps see them more frequently, not as infrequently, such that they actually run into problems and seeing other doctors per se. So DPP-4 inhibitors have modest renal benefits, but can be given throughout the life of a patient with type 2 diabetes with placebo-like side effects. I think I'll stop here. Thank you for your patient hearing. I think I don't have my prize question. I've already asked it. Thank you, chairpersons.
Thank you, Dr. Sanjay Shah, for such a nice presentation. He has told about that early diagnosis of diabetic kidney disease is very important, And at this stage, if we start SGLT2 inhibitor, after credence trial, it is clear that it will benefit long-term progression of renal disease. DPP-4 inhibitor can also be used throughout the diabetic kidney disease, and other medicine like glimepiride can be used in reduced dosage, glipizide as well as glinides can be used. Metformin can be used up to 30 eGFR at reduced dosage. So he has given a very nice presentation. Now this is open for question and answer session.
Yes, Kumar Saab.
Thank you, sir. You've taken a topic of my interest. Few things I like to correct in this thing. First of all, the KDOGI has expanded the criteria for definition of CKD. Now it does include normal creatinine as CKD stage 1 if they have proteinuria, RBCs in urine, or any abnormality in the structural component of the kidney. So that wise, it increases the pool of CKD.
Yeah, that's why the microalbuminuria. So
Yeah,
that also
again,
there's
microalbuminuria, it is a reversible entity. Now, if you have microalbuminuria, not all microalbuminuria will turn into macroalbuminuria. 30% of microalbuminuria do revert. So, or stay at the same, do not progress. So that entity has to be kept in mind. And as you have told that only 10% of these patients end-stage renal disease, I think that's a very underestimation of the data. Every year, we face around 2.5 lakh patients. It's the Indian data which says that they end up with end-stage renal disease in the clinic. And this data comes from big hospitals like AIMS, PGI. But still what is happening at the district level, it is actually underestimated. A huge population who are actually not even getting the therapy properly. We have such a huge population and we are only able to provide 30,000 patients and 2,000 patients with transplant. So that is the facilities as of now we have in our country. And CKD population, the problem is if you use this drug, now it's a progressive disease. Your pharmacokinetics are not going to work like what is written in the textbook. Your drug excretions will be delayed. Patients have low appetite. They will not take foods at that time. Sometimes because of loss of appetite, they only take once a day food. So hypoglycemia is the most dreaded thing in these patients. Once the sugar comes down, they end up in casualty. So we have to be very careful. Try to use drugs which has less duration of action and can be cleared early. Linagliptin is a good option which can be used. Ripaglinide is coming up. And insulin, shorter acting insulin, we prefer in these patients. Dialysis patients, what we do is we avoid OHS on the day of dialysis because invariably during dialysis they go into hypoglycemia. CAPD patients, again, because we use glucose as an entity in the peritoneal fluid, so they have hyperglycemia on the other end. So in these patients, we also add insulin to CAPD fluid to control sugars. Thank you.
Sure. Thank you, Bismay. You see, you might be a tertiary or quaternary level, basically, physician, because you treat kidney disease all the time, okay? This is basically data from a large population. So by the time you see them, they're all basically end-stage renal disease, so that's how it is. But your points are well taken.
Dr. Sanjay Shah,
yeah.
I think it was an excellent talk. Only one point I need to mention, rather compliment, is that whenever there is a talk on diabetic kidney disease, I think very important is, as you have mentioned, about the hypertension control. So even the Wikipedia studies, they have given that cognizance to hypertension control. Now with reference to hypertension, again, AC inhibitor would be very good, I think, in this. That also perhaps will be able to revert your microalbuminuria to a certain extent.
Yeah,
just a comment.
Yeah, just like SGLT2 inhibitors have an effect on the afferent arteriole, basically the ACE inhibitors and angiotensin 2 receptors actually have an efferent arteriolar, basically it dilates them and it lowers glomerular pressure, and that's data, renal and all the other ones that they have showed you earlier as well, which shows that there's improvement essentially in terms of renal outcomes as well. So you're quite right, sir, absolutely right.
Sir, recently, initially it was 3-point MACE, now it is almost 4-point MACE because heart failure is another very important and significant factor, and CKD is just related to heart failure because
Hand in glove.
Yes, so that is also very important. And another thing is, sir, gliptins, they are very useful during Ramadan. It is very, very good drug.
Quite right.
Less chance of hypo.
Yeah, I think
so that is very important.
The idea that a drug which is so innocuous has placebo-like side effects is really, truly wonderful. Allopathy, the side effect, perhaps linagliptin stands tall.
Thank you, sir.
Thank you very much. Thanks a lot.